there are sort of two paths to coming to see me. One is through what we call the warm handoff. And that would be a patient or a family coming in to see their primary care doc. And in that office visit, through a conversation with the doc, they would learn that the person might be having some emotional issues, some depression, some anxiety. We see a lot of people contending with anxiety and depression, along with the transitions in their lives, like divorce, grief, job loss, health problems, medical diagnoses. So when the need is made aware during an office visit, the doctor will come and find me and invite me into that office visit, with, of course, with the patient's permission. And when I come into the room, we have a brief introduction. The doctor may stay, may leave the room, and I do just a little bit of an introduction to what my training is, what this role can offer, and why it makes sense to have a person like myself in with the doctor practice. And when patients understand that having the role in the primary care really facilitates a great dialogue between the doctor, the family, or the patient, and it makes a much more seamless delivery of service, which we know increases people's healing and well-being, both emotionally and medically. This whole transition to having counseling in the doctor office is that the patients come and have a great relationship with their family doctor. And it is the trust and relationship between those two people, or that family and that doctor, that allows the doctor then to initiate the conversation about emotional concerns or about mental health concerns. The safety that a patient has with their doc really allows that smooth introduction to the role of counseling in that person's life. And the stigma is also reduced because people can come into the office. Anybody else in the waiting room, well, we could be in there for a variety of reasons: blood work, seeing your doc, paying a bill, whatever it is. People don't automatically assume that they're being seen either in a psychiatrist or in a therapist's office. So there's a degree of neutrality that is allowed in the whole environment. So that has really allowed for the reduction of a stigma. My role is to be short-term. It's brief treatment. And we know through a lot of research, what we know is that most circumstances that bring a person into the counseling relationship can be very effectively treated by what's called cognitive behavioral therapy. By design, it's a brief treatment. So we make that very clear in the beginning of the introduction to the role. And if a person prefers a more traditional version of counseling, the ongoing or sort of open-ended talk therapy, if that's the person's preference, we certainly help them connect to community resources. We have a variety of people working in the practices who can provide those linkages. And also, people in my role can also offer, we can help people find providers in the community who take a person's insurance. We can give them the resource information so they can reach out and make those calls. Yeah. How I approach the first appointment is to be very transparent about what my role is, the limits of my role, and then right at the beginning to invite the individual to make the decision whether they think that is the best track for them or not. If someone is looking for something other than what I'm offering, then I'll shift the rest of the appointment to helping them find the resources that they, in fact, prefer or think is good for them. Sometimes that involves bringing in other staff to help problem solve. I also, however, do an assessment. And that assessment I do through a narrative with the individual. I try to hear their story, have them tell me what's going on. I want to know what's pressing for them in their lives. I can't begin to think about ways to help that person or that family until I understand what their story is and what is happening. It's a judgment-free zone. So these encounters have nothing to do with determining the rightness or wrongness of what a person is doing. It's about evaluating the challenge that they're facing and how we can give them tools so that the challenge can be a little more smooth. I have a firm belief that with all the folks that I have met here and have worked with and are on teams with, we want to help. We know that people have very hard lives, and we ourselves have had hard spots in our own lives. And life isn't easy. Poverty is not easy, unemployment is not easy. We want to help. And the way we can best help is also to be in a good relationship, a respectful relationship with the patients who come to see us. And we can always improve what we're doing. We can do better. So people coming and asking questions, catching me around the practice and saying, well, what exactly is this? Or what's going on here? Because we want to do better. We want to be on your team. And so I would invite people to ask questions.